Everybody, I'm Carol Hodson. I am part of the International ECMO Network, and it's very late here in Australia, so just bear with me. Usually, this is the time that I'd just about be ready to go to bed, but I'm so excited that we've got our for 2024 our inaugural webinar. In 2025, we plan to run these more regularly, and we're going to use our ECMONet community, who are experts in the delivery of ECMO and who believe in really high quality care. So it's really fitting that we have Professor Alain Combes from Paris, from La Pitié, who, as you all know, runs some fabulous ECMO education and has led many large trials, including the Eolia trial, which has really changed practice for ECMO. And Alain has agreed to speak to us tonight about VA-ECMO and controversies. So Alain, thank you so much for your time and for agreeing to speak to us today. And I'm going to hand over to you.
Thank you so much, Carol, for this very kind introduction. It's a great pleasure for me to be with you today. ECMONet is central to our ECMO community because it's one very active research group which has been involved now for close to a decade. Was initiated initially by Dan Brody, and I do believe that ECMONet has a very bright future promoting ECMO in all its activities and also particularly, of course, research. So today I will discuss with you the latest about VA, ECMO, and also other TCS device which are used for cardiogenic shock. This is first my disclosure slide. So which mechanical assistance should be used for cardiogenic shock in 2024? We have still around the balloon pump. I will tell you a little bit about the balloon pump in a minute. The Impella family, and the news about the Impella with the publication of a major trial a few weeks ago. There's a device which is not that frequently used called a tandem heart, in which a cannula is inserted through the atrial septum into the left atrium to drain the blood directly from the left atrium, and then uses a centrifugal pump to reinfuse the blood into the aorta. This may be combined with a membrane oxygenator. In that case, it may be called LAVA ECMO. And of course, we have the classical form of ECMO, which is a VA, FEM-VA, for the most frequent and used indications. Just one word about the balloon pump. The balloon pump was tested against medical treatment in acute cardiogenic shock more than 10 years ago now, and did not show a benefit in terms of mortality. The mortality observed was 40% at 1 month, 50% at 1 year. And once again, there was no difference between the control medical treatment group and the balloon pump group. And this led to modifications of the guidelines of major societies, including the European Society, from a grade 1, you should do it, to a grade 3 for routine use of the balloon pump in cardiogenic shock in 2014. It still may be considered in patients who have mechanical complications of acute MI. The problem of the balloon pump is that it does not increase the cardiac output. It decreases a little bit the LV and diastolic pressure when it deflates, and the increase in the cardiac output is modest, less than 0.5 liters per minute for sure. This is the reason why it is less frequently used now. Do we have guidelines for those machines? Before just showing you the slides about guidelines, everybody should be aware of that new, it's not that new, it's been published a couple of years ago now, the SKY shock classification of cardiogenic shock from A to E, A and B being pre-shock state, C the classical form of shock, D and E the most severe form of shock. And this classification should be used for sure for conducting studies, but probably also at the bedside in CCUs to grade the severity of cardiogenic shock. So the latest guidelines, once again, from the European Society of Cardiology, as of now, only graded a 2A, meaning that those machines, including Impella and ECMO, should be considered in patients with cardiogenic shock as a bridge to recovery, bridge to decision, bridge to bridge, if it's a bridge to transplantation or to a bigger machine for like that for longer time. And once again, the IBP got a 2B for mechanical complication and a 3, so you should not do it routinely in acute cardiogenic shock. Now I would like to tell you some words about the Impella, which is the other pump which is used in patients who have cardiogenic shock, and specifically because there's been a publication of a major trial in the last few weeks. What is the Impella? The Impella is a micro pump, microaxial pump, which is inserted backwards through the aortic valve. The blood is drained from the left ventricle and re-injected into the proximal aorta. This is not just one pump. It's a family of pump, with the Impella CP being the percutaneous pump, the most frequently used as of now. And there is a bigger one, which was the 5.0, now it's the 5.5, which is a surgical pump, which needs surgical insertion through the axillary artery, which provides a blood flow which may be up to 4.5 liters per minute. The CP might be up to 3 liters per minute, but usually we do not use it over 2 liters per minute because the high risks of hemolysis, and I will show you also some data about that. So Impella, the Impella CP, the percutaneous Impella, was tested in the danger shock trial. What is the danger shock trial? It included patients with STEMI and signs of cardiogenic shock, including a lactate above 2.5, and patient could be enrolled before PCI and up to 12 hours after PCI. Very importantly, and we'll discuss that a lot when we'll talk about the other trial of ECMO, they excluded patients with out-of-hospital cardiac arrest with persisting Glasgow score below 8 after ROSC. So they basically selected a patient with the lower risks of death, especially because those patients who have cardiac arrest, prolonged cardiac arrest, have a dismal neurological prognosis. So patients were randomized to get first either the Impella CP or medical treatment with the possibility to escalate to VA-ECMO if needed. Once again, the most severe patients after cardiac arrest, those who had a Glasgow below 8, were excluded. This is the main result of danger shock. It was completely unexpected, but danger shock was a positive trial. The mortality in the Impella group was 46, and it was 59, which is unexpectedly high in the control group. It was also underlined that the mortality was not that different in the first 3 weeks, and it's after day 22 that a strong difference occurred, and that difference tended to widen over the weeks until day 180, which was the endpoint of the trial. So how to explain this result? Once again, the expected mortality for that type of patient should be between 45 and 50. Looking back to previous trials, registries, it has never been that high. And we also have a very important paper which has been published a couple of weeks ago by those guys in Germany who conducted the ECLS shock trial. I will discuss the ECLS shock trial, which is VA-ECMO in academic cardiogenic shock at the end of that talk. And the Germans here, they took their database and they looked into their database for patients who would have qualified for inclusion in danger. And what they did observe was that the mortality of those danger-like patients was 48, not 59. So basically, danger shock did not show a benefit in terms of mortality with the impella, because the mortality which was seen in the impella group is what just was expected from that type of patients. Danger shock showed a very important increase in mortality in controls. And once again, this mortality should have been less than 40% in the impella group to provide and to show a benefit of the device in that indication. Danger shock showed also a very high rate of adverse events, and especially of acute kidney injury leading to renal replacement therapy, which was, once again, unexpectedly high here in the impella group, was more than 40%. Also, a lot of sepsis and bleeding at the cannula insertion site. And back again to that German study looking at danger-like patient of the ECLS shock trial. In those series of patients, the rate of renal replacement therapy was only 15, which is the expected rate. So there's a major problem here, probably linked to the fact that the impella generates hemolysis. And I guess that most of the indications of renal replacement therapy in that trial was because of severe hemolysis linked to the pump. Another point which was also highly controversial regarding this danger shock trial is the heterogeneity between centers and countries. It took more than 10 years to be completed. It was originally initiated in Denmark, and in the last 2 or 3 years of the trial, German centers joined the group. And it appears that most of the difference is driven by patients randomized in Denmark. And as you can see here, the mortality is even higher for controls in Denmark. It was close to 65%, which is then here completely out of range of what is expected from that type of population. And there was no difference between impella and controls in Germany. And most of the excess deaths are actually linked to deaths related to refractory cardiogenic shock. It may have been, since it was an open study, that some of the patients in the control group of the danger shock trial did not receive escalation therapy to an ECMO. The rate was around 20%. It may have been higher here and expected to be higher. And to finish the discussion about danger, you may also have a look at this recent editorial published by the German investigators of the ECLS shock trial, underlining the issues with that trial. The study is okay from the methodological point of view, but there's many problems and unexpected findings. And the most unexpected and highly troublesome finding is that excess mortality in controls. So now let's have a look at VA-ECMO in the context of refractory cardiac failure. ECMO is different from the impella because ECMO provides biventricular support. The impella is only for the left side. The pump provides a high and stable blood flow. The impella CP is usually set up for a couple days, up to 1 week, 10 days. ECMO can remain in place for some weeks and maybe used as a bridge to a recovery, a bridge to another VAD or to a transplantation. And it's also a lower cost device. We're not talking here about 15 to 20,000 euros, US dollars, but to around 2,000, 3,000 euros or US dollars. So the title was Controversies, and I do believe there's no controversy now about the cannulation. The cannulation should be percutaneous for VA-ECMO. And we usually cannulate the venous side to drain the blood on one side and re-inject the blood on the other side to decrease the risks of ischemia because of venous blood stagnation. And we also systematically insert a leg perfusion cannula to decrease the risks of leg ischemia. And we have shown in our center in a before and after study that beyond the decreased risks in complications such as surgical site infection, cannula site infection, and bleeding, which were majorly decreased by the percutaneous Doppler ultrasound guided cannulation. It also translated in a lower mortality as compared to what we were doing before with the surgical approach for cannulation. ECMO has still a limitation. It's a device which increases LV afterload, LV and diastolic pressure because it re-injects the blood contracurrent within the aorta, and there might be risks of pulmonary edema because of this increase in diastolic pressures and volumes. It might also compromise the recovery of the ventricle by promoting dilation of this ventricle. There's been few strategies to manage this increase in the LV afterload, which are called unloading or venting strategies. The first one is to adjust the blood flow, which never should be above 4 to 4.5 liters. And in most patients, 3 to 3.5 liters are much enough to provide sufficient cardiac and vascular support. It's possible also to use inotropes like butamine to promote LV ejection. And we have 3 strategies which are most frequently used to vent or unload the ventricle: the balloon pump, the impella, and performing atrial septostomy. This procedure is not that frequently used. This procedure has some drawbacks. It drains the blood from the left side to the right side, leading to frequently complete closure and no opening of the aortic valve and blood stagnation within the left ventricle. Also problems with the atrial septal defect, which needs to be fixed when the patient is recovering. We have some data. For now, only retrospective. There's a big randomized trial ongoing, testing unloading in VA, but for now, this is the largest we have coming from the ELSO registry. We're talking about more than 12,000 patients here, and more than 3,000 of them got unloading, most frequently with the balloon pump. And that strategy was associated with a decrease in mortality up to 20%. There was some more bleeding, also some more hemolysis with the strategy, but the mortality gain was quite significant here, adjusted for confounders. So we have the balloon pump. The balloon pump will decrease the LV and diastolic pressure from 5 to 10 millimeters of mercury. This is a study we conducted some years ago here in La Pitié-Salpêtrière. When we measured the wedge, when the balloon was on, the mean was around 17, and it went up to 23, 24 when we stopped the balloon pump and went back to the baseline measurement when we restarted the balloon. The other strategy is to combine the impella. This is a tracing from a German center here, showing a much higher wedge, around 40 meters of mercury. Setting up ECMO leads to an increase in that wedge pressure, and the impella, which directly drains the blood from the left ventricle is able to completely normalize the wedge pressure and the end diastolic pressure into the left ventricle. This strategy is frequently used in Germany, and they have recently published their experience in a very large series of patients here, more than 400 patients. And when they compared the outcome of patients who got the combined therapy, combining VA-ECMO and the impella, they called that ECMELA, there was a better prognosis and lower mortality for ECMELA patients, and especially if the ECMELA was used very soon after VA-ECMO initiation. This is another slide from the ELSO registry in which those patients who got the impella tended to have more bleeding and more renal injury, back to the signal of acute kidney injury linked to the impella, which is probably related to intravascular hemolysis. So now I will review with you the potential indications and results of ECMO. I will show you very rapidly all the potential indication with a specific focus at the end of the talk on acute MI cardiogenic shock, because this is the indications for which we have the largest amount of data as of now. So for now, ECMO is most frequently used in the most severe patients. And when looking back to the SKY shock classification, most of the ECMO patients are getting the pump in the E stage, in the extremist stage, some are at the D phase, but very few actually at the class C of the classic form of cardiogenic shock. When looking back at recent registries, ischemic cardiomyopathy now represent less than 50% of the cases, including acute MI, and close to 50% of the patients are actually patients with dilated cardiomyopathy, non-ischemic cardiogenic shock. We do not have a lot of data regarding the impact of ECMO in that population of patients. This is a paper here from German centers. It is MCS combining impella and ECMO, showing a benefit of the early strategy of setting up a machine in non-ischemic cardiogenic shock, but it is clearly here an area for research in the coming years. Fulminant myocarditis, probably the best indication of ECMO in terms of results. Once again, back to the results of the ELSO registry. Here is the latest 10-year experience. More than 850 patients included here with the mortality at only 35. It's the lowest mortality reported for VA in most indications. It's because myocarditis is a disease which affects young patients and with a high potential for recovery. So this is one of the best indications, but it's a rare disease, so it's not that frequently used in our ICUs. After surgery, what is regular surgery or VAD surgery, transplant surgery, ECMO is more and more frequently used. This is one of the papers which has been published in the last years, which shows less favorable results, and we showed that the results are clearly linked here to the age of the patient at the time of implantation. I do not have enough time to discuss extensively this indication, but it's clear that every cardiac center, cardiac surgery center should have the opportunity and the possibility to set up VA-ECMO in patient crashing after the operation, just at the end of surgery or in the hours following surgery. The best results so far are for transplant surgery, in which we have a survival rate which is close to 80% now. Catastrophic PE, another very good indication of VA-ECMO. Those patients who have severe shock, high lactate, need for high-dose inotropes and vasopressors might receive VA-ECMO instead of the thrombolytics if the ECMO is immediately available. If not, of course, or if the delay is over 20 minutes, half an hour, the patient should receive thrombolytics. Is the best way to salvage the patients. Once the patient is on ECMO, we now have more questions. Should we wait with heparin? Should we go for surgical embolectomy, or should we go for catheter-based embolectomy? The catheter-based embolectomy strategy has improved a lot in recent years, and this is now our first-line strategy once the patient is on ECMO. And the benefit is huge, and usually ECMO can be weaned within 24 hours once the patient has been the clots have been removed with these catheter-based embolectomy. ECPR, we could talk hours also about that strategy, highly controversial. One small RCT in the US, which was positive, but with a lot of ethical questions because there was no rescue for control patients who reached the cath lab in which ECMO was set up. All those patients died, and the survival rate was close to 50 for those patients who got ECMO. It was tested in 2 other RCTs. This is the latest here from the Netherlands, in which this time there was no benefit of ECPR. The problem of ECPR is the complications, which were also higher in that paper, but the major issue with ECPR, the timing. I love that paper from Japan. It's retrospective, but it shows you the major impact of the delay between cardiac arrest and the time the ECMO machine is running. When it's below 45 minutes, the survival with good neurological outcome is over 20, but drops down to less than 7 after 1 hour of continuous CPR. Second, the benefit is mostly for patients who have shockable rhythm here. Initially, you can see those 2 curves here, and the benefit is within the 51st minutes for those patients who have initial shockable rhythm. So clearly, when it's too late, it's too late. If you cannulate a dead body, you will not succeed. And this is the criteria we apply now here in La Pitié for deciding for out-of-hospital cardiac arrest, which should be witnessed with the 0 no flow, with immediate bystander CPR. The initial rhythm should be shockable, and the collapse to ECMO time, the predicted collapse to ECMO time should be for sure less than 60 minutes. If you want to get 60 minutes, you should write in guidelines 45 to 50. Septic shock, we also have shown that there might be up to 5 to 10% of patients who have septic shock who might get an evolution towards cardiogenic shock with the low cardiac output syndrome. And in that international study, we showed that the survival rate of these patients might be up to 60%. We compared those patients to others who did not receive ECMO, who had been included in major RCTs of sepsis, and the survival rate was less than 15 in those patients. The time window here is very short to set up ECMO, but if ECMO is set up early on, once again, there's a huge benefit for this type of patients. And I will finish this talk by discussing acute myocardial infarction, because it is still one of the largest group of patients who might be take a good benefit from ECMO. Once again, for now, most of these patients are D or E Sky Shock classification patients. We have some retrospective database. This is one we published a couple of years ago, in which the ICU survival was close to 50. But once again, we are talking here mostly of class E patients, for which the mortality without ECMO is close to 100. And second good news, most of those survivors will be weaned from ECMO without the need for heart transplant or valve surgery, which is quite encouraging. And we have another RCT, which has been published just last year, which is the ECLS shock. And it is the other trial I would like to discuss more in detail with you, because with the danger shock, it's the two largest trial in cardiogenic shock published with devices ever. This was conducted in Germany, more than 400 patients randomized here, and a great deception. There was no difference in the mortality rate between these two groups of patients, 48 versus 49. And why is that? Of course, this is the New England Journal of Medicine. So the authors had to conclude that there was no difference. The mortality was not lower among patients who were treated with ECMO than those who received medical therapy. Well, should we abandon VA-ECMO after the result of ECLS shock? Surely not, and I will show you why. First, well, this is the conclusion of ECLS shock, but, well, when looking at the results, up to 1/3 of the control group patients were actually rescued by a device. It was a mix of ECMO and Impella, but 26% control patients did receive a rescue therapy. So once again, this should not be the conclusion of ECLS shock. The conclusion of ECLS shock should be in acute MI cardiogenic shock patients with early PCI. Day 30 mortality was not lower with the systematic versus the rescue use of ECLS, which is completely different. And knowing that rescue, once again, was applied to more than 25% of the patients. So this is the first point, which is problematic, but they were here forced to write that conclusion because it's the evidence-based medicine and the stats, the rigor of the stats, which needs to use those type of conclusion. Second, when looking into the population of patients, and here there are major problems with ECLS shock. Most of the ECLS shock patients were actually patients who had out of hospital cardiac arrest, and with prolonged time of cardiac arrest. The median time under the longest cardiac period was 20 minutes. So it is probable that most of the patients got at least 30 minutes of total CPR. When looking back to data from the same group, the rate of cardiac arrest was below 50, around 40 to 45, and not 80%. Once again, like in ECLS shock, the danger shock trial, which excluded patients with low Glasgow, it was only 20%. So there is a major problem here, and specifically because hypotension was the only hemodynamic variable to define cardiogenic shock. And as you know, there's many patients with cardiac arrest which have the post-ROSC resuscitation syndrome with major vasoplegia. So what was the actual hemodynamic phenotype of those patients? Did they have low versus normal to high cardiac index? Once again, this data did not belong to the inclusion criteria. And if you look into the details of the SCAI shock classification, starting at that stage C, D, and E, cardiac index below 2.2 is a part of the definition of the SCAI classification. And we know that ECMO cannot rescue patients with normal or preserved or increased cardiac output. We know that for years. These are data from our group in Paris here, a series of more than 1,000 VA-ECMO. And for those refractory vasoplegic shock, the survival rate was 0. The mortality was 100%. The third problem of that study was the very low rate of use of NV unloading venting in these patients. I've showed you some minutes ago the impact of LV unloading here in a retrospective database from the ELSO registry with a mortality which was decreased by close to 20% with that strategy. ECLS shock, less than 6% of the patient did receive a venting device. They actually had in the protocol a recommendation for unloading, which are the classical indications for unloading. And when there was no arterial waveform pulsatility, there was the opening of the aortic valve, or when the time velocity integral was less than 10, which is closely related to a cardiac output, cardiac index of less than 2.22 liter per minute per square meter. So we get here then less than 3% with a low cardiac output if we believe their data about LV unloading, not to mention that LV unloading is associated with better prognosis when it is applied to these patients. And we are back to the inclusion criteria here, and we do not know the phenotype. And it's probable that a large proportion of these patients are the preserved cardiac output and not a low cardiac output syndrome. Next. Another point which was highlighted by experts is very short duration of ECMO. It was only 2.7 days, where in the ELSO registry for the same patient was 5 days. It was even longer in our series of super severe cardiogenic shock patient, was 7 days. So there's clearly another questions here about the hemodynamic phenotype of those included patients. Did they actually need ECMO? And there might be another question also about weaning. Did those patients were weaned too early from VA? Actually, for those who needed VA ECMO support. One of the last points is the very high rate of deaths for refractory cardiogenic shock, which is difficult to explain for patients on VA, and which also questions the under-utilization of MCS in control patients. This was 55% of the patients in the control group who died of refractory cardiogenic shock, not receiving a device, which also questions here the management of the patient in that study. And the last point is the very low rate of patients getting a VAD for non-recovering LV failure. In their previous trial in the IBP Shock 2 series was close to 6%. It's much higher in other series of patients. In our super severe patient, it may be up to 10 to 15% of the patients. And once again, question here, the type of patients who had been included in that ECLS shock. So, well, after those two major trials, we may have more questions than answers. And it is for sure very, very difficult to conduct those research in severe cardiogenic shock patients. This is something we summarize with Susanna Price and Bruno Levy in that small editorial in intensive care medicine. It's very difficult to select the good population of patients. Most of the class C patients are not as sick as good indications for VA ECMO. We may wait a little bit for them. On the opposite, class E patients are dying of refractory cardiogenic shock. If you randomize them into a trial, if they are randomized to the control group, they might be rescued by ECMO as soon as they are randomized. So it is virtually impossible to demonstrate the benefit of the strategy. And beyond the type of patient, the experience of the team is also making a huge difference. We have another trial in France, which is called the Anchor trial. I'm the PI of that trial. The difference between that trial and ECLS shock is that we systematically combine VA ECMO with the balloon pump for all patients, and we have a strict definition of refractory shock with which needs the recourse to VA ECMO. And with that, I would like to thank you very much. And this is actually an invitation to Paris, to our events, and especially our Congress ECOS TCS, which is usually in late June. Thank you so much for listening.
Thank you so much, Alain. That was wonderful and a tour de force of VA-ECMO. So we have one question in the chat already from Hergen Buscher from Sydney in Australia. And he just said that it's interesting that both in danger as well as in the matched data, the mortality benefit only appears late. And what is the impact of unloading the ventricle or additional weaning options?
You're talking about VA-ECMO, the ECMELA strategy.
Yeah.
When looking at German data, it's only registry data. It has been well done. This is a propensity matched analysis. And especially if the impella, which is most frequently the CP, is set up within the 2 to 3, 4 hours after ECMO initiation, the benefit in terms of mortality, which is expected, is between 15 and 20%. It's retrospective. This might be biased by indication for sure, as always. The group from Benedict Raj has started the NARCITY. I think they have already randomized more than 30 patients in that trial. They randomized VA alone against the impella associated with VA, the ECMELA strategy. So it may take an additional maybe 2 years to reach the end of that trial. We have a trial which will start in France with the balloon pump anytime. I got fundings from the French Ministry of Health just a couple of months ago, and we are just now setting up the trial. And there is another one which belongs to a platform of ECMO trials which has started in the Netherlands. So we may have more data about unloading and the strategy to apply to these patients in the coming years.
Thank you. I'm just going to introduce our other panelists for a moment. I'd like to introduce Dr. Aidan Burrell, who's from the Alfred Hospital in Melbourne. Aidan is also part of the International ECMO Network, and Professor Thomas Muller, who is from Regensburg in Germany, who has been one of our long-standing members of ECMONet. Thank you, Aidan and Thomas, for joining us to speak on the panel or even just to ask questions. I think the thing is that today is about a conversation. There's been a lot of controversy around VA-ECMO, and I think, as you can see, Alain has walked us through many of them. We've got another question in the chat, and I'll start this off from Edan Morris. And Edan is based in Australia, in Sydney, but she's actually currently in Toronto. She says, "Thank you for the great talk, Alain. Outside its use as a venting strategy, when would you reach for an impeller over VA-ECMO? And separately, would you consider it in aortic regurgitation?"
Well, if it's a major aortic regurgitation, the treatment is surgical because in the ICU, it's very difficult to manage these patients, and they usually crash within hours if surgery is not possible. What is the indication of the impella? Once again, the results of danger, if you just look at the p-value and the stats, this might be considered a positive trial. But all the experts pointed out the major issue is the control group, and especially in Denmark. Why is that? Why is that the mortality was 64 in Denmark? Once again, this trial included less severe patients than in most registries, and that, for sure, those patients included in the German trials, for which the expected mortality was around 50%, 48 to 50. Why is that? It was an open trial. And as when you look at the data in the paper supplement, most of the excess deaths are actually deaths of refractory cardiogenic shock. They do not have data about the hemodynamic profile of their patients. It's the same for ACLS shock, which is also a problem because most of these patients, we would need some more data about the cardiac index, about the wedge, about the management, about the drugs, about the timing of weaning, about the criteria for weaning, etc. we will never have access to the data because they did not collect those data. Is the impella useful? What is the indication? It's for sure for those patients who have only LV failure. It cannot be applied to patients with biventricular failure because the pump only vents the left ventricle. And well, it's a pity because there was another study ongoing in the US, the Recover 4 trial, which was stopped by the company, was the company funded trial, and they stopped the study for ethical reasons. You remember the Xigris controversy. I do believe we are exactly facing the same issue now, not except because Xigris was super expensive, and we face the same issue here with a super expensive device for which the evidence is highly questionable. And I do believe most of the big agencies, EMEA, FDA, should ask for a confirmation trial here in the setting of acute MI, because it's probably the most homogeneous group of patients. But this excess mortality in the control group is highly problematic. What has been observed in that study is that the mortality in the impella group is just what is expected with medical treatment. The benefit, if any, should have shown a mortality be below 40%.
Thanks, Alain. The second part of that question before I hand over to Thomas and Aidan is if there's no venting device in situ at the time of cannulation to ECMO, what is your preferred venting strategy? Is it a balloon or would you go to an impeller?
So in our center here in Paris, we always use the balloon first line. I would say in up to 80% of the patients. We do not use the balloon for patients for whom the expected duration is ECMO is short because it's drug intoxication, it's Takotsubo. The heart is not dilated, some forms of myocarditis when there is some residual ejection, might be patients for whom the balloon might not be needed. In other cases, we set up the balloon, especially for patients who have dilated cardiomyopathy, end-stage heart failure. The expected decrease in the wedge is 5 to 10 millimeters of mercury, but still, it might fix up to 70 to 80% of the problems encountered in these patients. When the balloon fails, we just remove the balloon and we switch to the impella CP. This is our strategy. In Germany, they systematically go for the impella CP first line. I don't know what is the best. In the trial we are launching in France right now, we will compare immediate balloon plus ECMO combined in the interventional group. And in the control group, we will go for ECMO alone with the possibility to escalate to the impella or the balloon, but most frequently the impella if the strategy fails in the control group. So it may take an additional 2 to 3 years to have the results of those unloading trials.
Yeah, we'll look forward to those results, Alain. Thank you.
This is small signal in favor of the balloon pump in the ELSO registry data. But one thing, it might be biased by indication. Those patients who received the impella might have been sicker. We don't know that. They say there have been adjustments, but well, you know, retrospective data are always questionable.
Thank you. Thank you. I'm going to hand over to Aidan now. Aidan, do you have any questions that you wanted to ask of Alain?
Yeah, I do. Thanks, Alain. Very excellent talk. Very fascinating. I thought I would just steer away from the AMI controversy and try and go into the controversy of sepsis. The results you presented have always made me, it's always been really curious to me, the very high survival that you've had with VA-ECMO for septic shock. And I think you sort of hinted at the fact that for vasoplegic shock, the results tend to be very poor, but you managed to find a population who maybe do well. And I'm just really curious about that because it's a common call we get when somebody is failing in sepsis, and the outcomes we've had in Melbourne have been very poor when we've tried it. But the papers that you've cited often are quoted and say, look, if you pick the right patient, it can be good outcomes. So I'm just really curious to know what's the phenotype like, and how common is it?
Yeah, it's actually a central question here, and it may also explain why the results of the CLS shock trial were negative. ECMO cannot rescue patients who have vasoplegia with a preserved cardiac output. We have those data from our group showing that, and most of the paper published also show that fact. Those patients we included in our septic shock registry were patients who had a low cardiac output syndrome. Those patients were dying with a cardiac index which was below 1 liter per minute per square meter, and most of these patients had a preserved or high or elevated systemic vascular resistance. It's a form of septic shock with an evolution towards a cardiogenic shock phenotype with a low cardiac output syndrome. And it's for sure not for those dying of refractory vasoplegia. In those patients, ECMO cannot rescue. It's not because you would increase the blood flow in the aorta by 2 to 3 liters that will change the outcome of the patients. Most of these patients, the microcirculation is dead, it's closed, and whatever you do, you will not.
Oh dear.
It's frozen.
Yeah, never mind. So maybe Aidan, you could pick up the thread for a moment until he unfreezes.
Yes, I think he's explaining a key variable is the cardiac output in these patients, and I think that's true. And I understand what he's saying. I guess the second part to my question is just around how common are those patients, and they seem to be more common in France for some reason than we see. But I'm curious. I don't know, Thomas, if you have any experience as well with that septic group.
We do see them. Hi, everybody. We do see them regularly. And I think it may be that we sometimes miss them. Yeah, they are patients in severe septic shock and they have high dose of vasopressors. And there is a small cohort among them who actually have this septic cardiomyopathy. And we have the same experience. Yeah, you only need a few days where you need perfusion. And for these patients, ECMO can help. And actually, we see also, I mean, it's not controlled, but our impression is that these patients profit a lot. They are not for a long time on ECMO. They are maybe 4 or 5 days on VA-ECMO, and then very often the heart recovers. So I see a chance for these patients, and I think that's one of the options where we have an advantage with providing VA-ECMO support.
Terrific. Thank you.
We have now lost Ada.
I think we have lost Alain, and I've just messaged him to see if he can rejoin, but I haven't had an answer. So look, we're almost at time anyway. We're 2 minutes away from the hour. So I think that we've had a really great conversation about VA-ECMO, and I'm very sorry that Alain isn't here for us to say a big thank you to him for his wonderful tour de force of VA-ECMO and the controversies surrounding it. Thank you to Aidan and to Thomas for joining at the last minute as panelists, because the ECMONet hadn't really planned to have a panel, and I really appreciate you two both just stepping on at the last minute to help with questions. There is just a couple of comments saying thank you for the great talk. So on that note, I'll say thank you, and I'll just give everybody a heads up that we will continue these webinars next year as part of the International ECMO Network's plan to try and improve the management of ECMO globally. So thank you so much to everybody, and good day or good night, depending on where you are in the world. Thank you.
Yep.
Thanks, Carol.
Bye-bye to everybody. Bye.
Bye.
Thanks, everyone.